My name is Dr. Naila Siddiqui Kamal. I am the Director for the MedRet OBGYN telehealth program. This lecture is about managing abnormal vaginal bleeding. We will first discuss the subject as a whole and then focus on how this would be managed as a telehealth case. The learning objectives for this talk are to explore different abnormal vaginal bleeding patterns, work out the diagnosis through critical thinking and evidence-based structure, revise the management options, reflect on the MedRet model of safe telehealth practice in context of abnormal vaginal bleeding management. The common abnormal bleeding patterns include irregular bleeding, either more frequent or less frequent than the normal 28-day cycle. A variation of 2 to 4 days is considered as normal. Further abnormal patterns include intermenstrual bleeding, postcoital bleeding, heavy menstrual bleeding, and postmenopausal bleeding. Though these bleeding patterns can happen at any time according to the menopausal status, generally the age groups for the relevant bleeding patterns are shown in this infographic. In order to manage a patient with abnormal uterine bleeding, assess the amount of bleeding, the timing, any associated symptoms, and the impact on the patient. The amount of bleeding can be assessed obviously by the clinical presentation as well as what the patient gives in the history. However, sometimes the history cannot be a reliable source, as either the patient will understate the presentation or overstate. Any patient who gives a history of abnormal bleeding, an assessment of anemia is absolutely paramount, and this can be done through the history, examination, and investigations. We will discuss further on that within the limitations of basic telehealth practice, how this assessment can be done. Once this information is available, critical thinking should be done to build a likely short list of differential diagnosis. Determination of the causes of abnormal uterine bleeding in the reproductive years remains a major challenge for investigators, clinicians, and educators. As a result, in order to obtain clearly informative basic science as well as translational and clinical investigation, a comprehensive approach to both investigation and categorization was needed. In response to the challenges described above, the FIGO Multidisciplinary Committee has developed two systems: the FIGO Abnormal Uterine Bleeding System 1 and FIGO Abnormal Uterine Bleeding System 2. The System 1 describes the parameters of normal menstrual bleeding, establishes a mechanism for defining the various symptoms that comprise the abnormal uterine bleeding, eliminated the terms such as menorrhagia, oligomenorrhea, metrorrhagia, and dysfunctional uterine bleeding. While as System 2 is also known as the PALM COEN system, which provides a structured infrastructure for research, education, and clinical care by categorizing the various possible causes or contributors to the symptoms of abnormal uterine bleeding in the reproductive years. This mnemonic stands for polyp, adenomyosis, leiomyoma, malignancy, which includes hyperplasia, and the COEN stands for coagulopathy, ovulatory dysfunction, endometrial, iatrogenic, and not yet classified. These various underlying pathogenesis can also be considered under two broad groups, such as the gynecological causes for abnormal uterine bleeding and the non-gynecological causes of abnormal uterine bleeding. Hence, generally speaking, In the gynecological causes, you would include the polyps, adenomyosis, endometriosis, fibroids, hormonal dysfunctions, malignancies, or infection, while as non-gynecological could include endocrine problems such as thyroid disease, prolactin abnormalities, trauma, such as when a patient might be using ring pessaries for prolapse, medications such as blood thinners. We will now go over each one of these separately in order to see what are the peculiarities of each pathogenesis, and then in the end we'll do an exercise to see how to do critical thinking in order to come to a plausible differential diagnosis and finally to a diagnosis. Abnormal uterine bleeding can be due to endometrial polyps as well. Endometrial polyps may present coinciding with cervical or endocervical polyps also. The presenting scenarios usually include intermenstrual bleeding, postcoital bleeding, vaginal discharge, or postmenopausal bleeding. Speculum examination can reveal the status of the cervix or presence of any cervical or endocervical polyp, which is just about seen protruding through the arse. Colposcopic assessment can further be helpful in any suspicious looking polyps. Small polyps can be evulsed. However, it's important to know the tail. It's important to visualize the tail of the polyp, as that's where the bleeder will be, in order to cauterize it or use silver nitrate to stop any bleeding. Endometrial polyps require a hysteroscopic review and polypectomy. Large based polyps require resectoscopes to be used to resect them. Ideally, outpatient hysteroscopy should be planned in patients where this is feasible, such as women who have been sexually active or have had children. In cases where patients may have had cesarean sections or the os is very tight and it's uncomfortable, then under either sedation or general anesthesia, hysteroscopy and biopsy and polypectomy will need to be done. Adenomyosis is a gynecological condition characterized by ectopic endometrial tissue presence within the uterine myometrium. The prevalence of adenomyosis is about 20 to 35%. Most commonly, the presenting signs and symptoms, though they vary, but mostly patients present with painful cycles and heavy menstrual bleeding. Risk factors for adenomyosis also include conditions leading to increased estrogen exposure. Underlying pathogenesis is that there is invasion of endometrial glands into the uterine myometrium. Why this happens is largely unknown. The age group is usually between 35 to 50 years. Associated coexisting conditions can often be endometriosis or leiomyomas. Patient usually presents complaining of painful periods with heavy menstrual bleeding or chronic pelvic pain as well. On examination, uterus is found to be uniformly smooth, enlarged, soft, globular, with a boggy feeling, and sometimes is tender as well. Cervical excitation sign is negative. In order to assess adenomyosis, following a good history and examination, an initial beta HCG qualitative test, that is a pregnancy test, should be done to exclude the possibility of a pregnancy, and then a transvaginal ultrasound scan is indicated, which has a sensitivity of 72% and specificity of 81% in diagnosis of adenomyosis. When there is a question about excluding a malignant process as well, then a further MRI might be helpful. However, this remains to be a decision by expert gynecologists, and the primary care physician should be referring the patient for that decision. The imaging usually show diffusely enlarged uterus with some cystic areas within the myometrium. Treatment for symptomatic adenomyosis includes anti-inflammatory medications, hormone therapy, and endometrial ablation. For severe symptoms that do not respond adequately, hysterectomy has been conventional surgical management. Uterine artery embolization may be an alternative option for patients who do not wish to have a hysterectomy or who wish to preserve their fertility. However, there have been studies that have concerns with regards to the maternal fetal circulation following uterine artery embolization if a pregnancy happens. Mainstay of treatment for women who are of childbearing age, who are not planning a pregnancy just yet, levonorgestrel coated intrauterine device. However, women who have completed their family and other medical therapy is quite refractory, then a hysterectomy is indicated. Although endometriosis is not mentioned in the FIGO system 2 classification, however, I am mentioning it here as often adenomyosis may occur with endometriosis. So women with endometriosis develop tissue that looks and acts like endometrial tissue outside the uterus, usually on other reproductive organs inside the pelvis or in the abdominal cavity, and the most common site is around the ovary. However, it can also be found around uterosacral ligaments, round ligament, with peritoneum on pelvic organs or the lining of the pelvis. In rare cases, it can be found in rectum, bladder, lung, or on the umbilicus, and it is uniquely presented with bleeding at the time when a woman has her monthly cycle from these areas. The risk factors for endometriosis include women who have first degree relatives with the disease, women who are giving birth for the first time after the age of 30, and women with an abnormal uterus such as biseptate, etc. The symptoms of endometriosis are typically painful periods or dysmenorrhea, but this is especially signified by the fact that this is a cyclical pain. Deep dyspareunia, abnormal or heavy menstrual flow, subfertility associated because of the complications of endometriosis, painful urination during menstrual cycles, painful bowel movements during menstrual period, other gastrointestinal problems such as diarrhea, constipation, or nausea. The diagnosis can be made in most of the cases by the classical history which is presented by the patient in cyclical painful periods, as well as sometimes family history. Investigations include laparoscopy and biopsy, which is the gold standard for diagnosis. Ultrasound will only show if there is endometrioma present, and in more advanced cases of complex adhesions and multiseptate suspicious cysts presenting, a workup with CT scan or MRI may be indicated, but this would be done under specialist review. Endometriosis can be staged according to its severity, and the criteria for staging include extent of the spread of the tissue, involvement of pelvic structures in the disease, the extent of pelvic adhesions, the blockage of the fallopian tubes. The stages are stage 1 being minimal involvement, stage 2 mild, stage 3 moderate, and stage 4 severe. The stage of endometriosis does not necessarily reflect the level of pain experienced or the risk of infertility or symptoms present. For example, it's just possible that a woman with stage 1 could be in tremendous amount of pain with a low quality of life, while as a much advanced and complicated stage 4 endometriosis patient might be totally asymptomatic. The general treatment of endometriosis involves relieving the pain, controlling the amount of bleeding, and controlling the disease from worsening. It is important to know what the fertility aspirations of the patient are, as some treatment will actually prevent fertility. In young girls, the oral contraceptive pill is quite helpful in controlling both the pain as well as the bleeding. Levonorgestrel coated IUD is also indicated in cases where this might be a suitable option. Where there are large cysts present, which is generally more than 4 or 5 centimeter size, ovarian cystectomy by means of laparoscopy is also indicated. Abnormal uterine bleeding could be due to leiomyomas or fibroids. Fibroids originate from uterine smooth muscle cells or the myometrium, whose growth is primarily dependent on the levels of circulating estrogen. Risk factors include early menarche, nulliparity, obesity, late menopause, and family history of fibroids. Afro-Caribbean descent is also a significant risk factor. There is a decreased risk for uterine fibroids with increased parity, late menarche, smoking, and the use of oral contraceptive pills. Research suggests that the starting event for fibroid begins with a single uterine smooth muscle, which is then followed by deviation from the normal signaling pathways of cellular division. Main presenting features are abnormal vaginal or abnormal uterine bleeding. They may be associated with pelvic pain and abdominal pain in cases of large fibroids, pressure effects on the bladder or the rectum, or they may be totally asymptomatic and are discovered as an incidental finding. During assessment of the patient on the whole, while doing the abdominal examination, one may find a mass arising from the pelvis into the abdomen. It might be smooth, or it might have a nodular contour. This depends on whether it is a single fibroid uterus or multiple fibroids. The consistency is typically firm. In cases of large pedunculated subserous fibroids, the mass may be more. On speculum examination, one may find prolapsed pedunculated submucous fibroids coming through the os. Vaginal assessment confirms the presence of a bulky uterus with fibroid consistency. Otherwise, in small fibroids or with fibroid change in myometrium only, the uterus may not have any positive findings. Investigation for a woman who presents with abnormal uterine bleeding obviously includes, number one, a workup for diagnosis of anemia, and subsequently transvaginal ultrasound can be quite helpful in identifying the presence of fibroids, the number, as well as the type of fibroid. The fibroids which are present within the myometrium are called as intramural fibroids. The ones which are in the towards the cavity are the submucous, and the ones which are towards the outer side of the myometrium are subserous. Management of fibroids depends upon the patient's age, presenting symptoms, size, number, and position of fibroids, and future fertility plans. Management can be divided into three headings, that is conservative management with surveillance and observation, medical management, which is to control the bleeding and pain if that is associated, and also thirdly, the surgical management. There is definitive surgical management, such as a hysterectomy, but that remains to be the last option, and in cases where the presentation is such that a hysterectomy is indicated, such as in severe pain and extremely enlarged uterus. Otherwise, conservative surgical management includes uterine artery embolization, myomectomy, MRI guided focused ultrasound. It's important to cover another aspect here with regards to fibroids, as patients may present in that particular condition, and that is the degeneration of fibroids. As fibroids enlarge, they outgrow their blood supply, causing various types of degenerations. These are mostly of the following types: hyaline degeneration, which is mostly 60% of the time; cystic, which is 4%; red degeneration, 3%; calcareous, 4%; or sarcomatous degeneration, which is less than 1%. The commonest type of degeneration is the hyaline degeneration. The patient may present with acute pain, usually focused on the site of the fibroid. Some patients may have dull aching chronic pain, which may be associated with. Patient may also have fever, which occurs when fibroid degeneration happens in pregnancy. Bleeding is a rare occurrence. However, in degeneration of fibroids, severe bleeding can happen. It's noted that patients may have leukocytosis. During pregnancy, the uterus may have changes which cause the blood supply to be blocked or severely reduced, which causes severe pain and discomfort. The pain during red degeneration in pregnancies is because not only of due to reduced blood supply, but also the release of prostaglandins from cellular damage within the fibroid. Management usually is rest and treatment with non-steroidal anti-inflammatory medications, as well as prostaglandin synthetase inhibitors. In rare condition or rare cases, patient has to be considered for surgery, but obviously this is a decision to be made by means of multidisciplinary team review and within a specialist unit. Among uterine malignancies, endometrial cancer is the most common gynecological malignancy in the Western world that presents as postmenopausal bleeding. It can occur as abnormal uterine bleeding earlier in premenopausal women who have risk factors for endometrial cancer, such as high BMI or excessive estrogen exposure, such as in polycystic ovarian syndrome. Cervical cancer also results in intermenstrual bleeding or postcoital bleeding. Ovarian cancer is less likely to result in abnormal uterine bleeding, as it initially presents with bloating. Unfortunately, when the disease has spread to the abdomen and pressure effects are on the bowels, which result in symptoms such as bloating, or ascites is present. The second part of the mnemonic of FIGO system 2, which is COEN, starts with coagulopathies. These are estimated to cause 13% of women presenting with heavy menstrual bleeding. The majority of women suffer from von Willebrand's disease, and this should be looked for especially in young girls who present with abnormal uterine bleeding. Anticoagulant and antiplatelet therapy are also considered as part of abnormal uterine bleeding C, that is abnormal uterine bleeding due to coagulopathy. Compression caused by large fibroid uterus may lead to venous thromboembolism. Ovulatory causes include the anovulatory cycles, where unopposed estrogen effects on the endometrium causes proliferation and thickening, resulting in a breakdown of the endometrial tissue and heavy menstrual bleeding, as well as alteration in the frequency of menstruation. This is seen in extremes of reproductive age. Previously, this was called as the anovulatory dysfunctional uterine bleeding. Other causes can be hyperprolactinemia, hypothyroidism, as well as factors such as obesity, anorexia, weight loss, mental stress, and extreme exercise. Typically, women in this particular group of ovulatory abnormal uterine bleeding have menstrual cycles that fall out with 38 days or have a variation of more than 21 days. Drugs that cause dopamine levels raised or lowered also are considered in this group. Endometrial causes of abnormal uterine bleeding, or AUBE, occur in context of a structurally normal uterus with regular menstrual cycles without evidence of coagulopathy, and that is likely due to underlying endometrial cause. The process of menstruation is not fully understood. However, there are theories which suggest there is hypoxia, inflammation, hemostasis, and angiogenesis disorders which play a crucial role in shedding and subsequent scarless repair of the functional upper layer of the endometrium. Iatrogenic causes of abnormal uterine bleeding include exogenous therapy, which may lead to unscheduled endometrial bleeding. This is typically associated with continuous estrogen or progesterone therapy, or the main cause of abnormal uterine bleeding, iatrogenic, is considered to be the intrauterine device, which leads to a low level or low grade endometritis. Lastly, the FIGO system 2 classification considers not otherwise classified. Needless to say that abnormal uterine bleeding is a huge topic. We have touched upon the main underlying pathologies which can be a cause for abnormal uterine bleeding, and in the last section of this presentation, a couple of slides are given to give an overview of the workup and investigations. There is a framework which MedRet has put forward for reviewing of cases while doing a telehealth consultation. This framework identifies various steps, and most importantly, in each step asks the question whether the patient is safe to be managed as a telehealth patient, or is there an indication for the patient to be referred for further assessment in a hospital setting, or requires examination. We will be touching upon this in a live session with examples. So this lecture comes to an end. Thank you for your time.